Thanks for choosing us to potentially have an appointment for surgery. We really appreciate it. I want to talk to you guys a little bit about what we've done in the last 25 years, that particularly in regards to knee replacement surgery, to try to make it easier for people. I also want to tell you we do all non-operative options for knee arthritis as well. When I started practice years ago, most patients' knee arthritis problems were managed by orthopedic surgeons and a lot of providers treating, and now a lot of options out there. And I think they're very appropriate for a lot of patients that can buy you time. Generally, people looking at considering surgery for their knee are more advanced stages. They might have been told they're bone on bone. They may have a deformity in their knee, or they're like bow-legged or not-beat. Really, at that point, a lot of the conservative options that we hear about, the stem cells and stem wave and all that, are probably going to be less effective. That's the time you want to discuss it with the surgeon. When the structures outside the inner knee joint are being involved in your arthritis problem, like you're getting the deformity, it can affect your long-term result with knee replacement if that's going to ultimately be the best solution anyways. So that being said, we do cortisone shots and lubrication shots, regenerative. We have doctors that do regenerative type injections as well, and those are certainly options that can be discussed. What I want to talk to you about is what I've seen in my career. I, in 2009, converted from doing hip replacement posteriorly to an anterior hip replacement and saw such a big difference in patients' recovery. Ultimately, it doesn't matter so much on the end result. The patients do about the same, you look at them a year later, but getting from point A to B was such a drastic change for patients. And when you take a long time to heal from surgery, it really can affect your life, because a lot of us are over 50 getting these surgeries. And, if you take a year out of your life to recover from surgery, that's a big part of what you got left. So I've been searching for ways since that point of trying to make knee replacement easier for patients. It's traditionally known to be not a real easy recovery. When I started doing these in 2001, I would just tell everyone it's going to take a year. And that was pretty routine back then. We'd be following patients every few months, then the progress of the first year until they got over the hump. That was pretty routine back in those days. It still can take a year for some patients after a knee replacement to recover, but of all these implementations that I'm going to talk about, that's becoming rare. It's becoming unusual to take that long to recover after the surgery. And we are getting to the point where knee replacement for a lot of people are almost getting to be as quick of a recovery as anterior hip replacement. So some of the things that I kind of changed over the years, and some of these are unique and are slowly being adopted. In about 2012, I stopped using tourniquets for knee replacement, which is the structure they put on your thigh that was traditionally used to slow blood loss after the surgery. We've adopted a lot of other cool things to minimize blood loss, including a medication. Again, I just didn't find that to be necessary anymore. And what we found, and what I found personally, is people didn't have as much pain in their thigh after surgery. Their quad muscle strength came back quicker. And I saw that be a big step forward on recoveries. Around 2016 or so, I started working with glueless knee replacements. That's becoming more common nowadays as manufacturing is catching up in the knees that were used in hips years ago. We stopped gluing hips in about 20 years ago in the United States, and now there's a big trend going away from that in knee replacement. And we're finding that there's probably more longevity in your replacement, whereas cement could sometimes fail after 10 to 12 years. A cementless knee replacement is probably the last 20 to 30 years with the metallic components. The plastic liners that go in between knee replacements have gotten significantly better over the last decade. They infuse vitamin E in the plastic now, an antioxidant. And where it wasn't terribly common to see someone fail and need that replaced in the first 10 years, that's very unusual now in the first 20 years. So the parts that all the surgeons are putting in have gotten better, and we're making improvements in that to obtain the similar results we got in hip replacement. One of the other things that has really kind of taken stride in the last 5 years, and we adopted this a long time ago, is getting people prepared for the surgery a little better. That might involve prehab, where you see a therapist prior to surgery, particularly if you have a real stiff knee, or you fall a lot, your balance isn't great. Some people will need to get several sessions in there. Looking at things like if you have problems with swollen ankles from medical conditions and things like that, we should probably try to get rid of that swelling before we do the surgery. So some people will be sent to a lymphedema specialist. Some will give you advice on trying to get rid of ankle swelling. And we've implemented some supplements to help reduce swelling after surgery. So some of the things I want to talk to you about in that topic, as well as we look at a lot of factors that we never really knew affected healing, such as your nutrition status prior to surgery. A lot of times we do supplements with protein leading up to the surgery and after surgery to help wound healing. We have better parameters now if you're diabetic on assessing your risk for getting a staph infection after surgery. We look at things like vitamin D levels now. We know vitamin D deficiencies may have affected wound healing, so we make sure your vitamin D is optimized prior to surgery. Looking at bone density, we know if that your bones aren't great, you have a higher chance of having a heart failure after surgery. So we're a lot more attuned at looking at that prior to surgery, maybe making some corrections that can make your bone density improve prior to operating on you. So I got involved with a lot of the navigation and robotic surgeries over the years that have come in. I've definitely seen an advantage for an experienced surgery of having some feedback on where he's putting your parts in alignment during the surgery. Some of the disadvantages of things like robotics is most previous generations, and this is changing, they're getting more autonomous as time goes along, but the actual implementation on where they are in space require the surgeon to oftentimes look away from the surgery field so he doesn't have his eyes on your knees. And I've always been a proponent that the surgeon should keep his eye on prize. He shouldn't have to look away to find any information. So I got really intrigued when this company came out with augmented reality total knee replacement. I've been implementing that for the past 4 years for all my knee replacements. What that involves is I obtain a virtual hip center, so I know where the patient's middle of their hip is, I know where the middle of their ankle is, I know where their surfaces are, what kind of angles or natural inclination of their joint is, and I'm better able to match what their natural anatomy is at the time of surgery. And I found that to be a real benefit, even having 25 years of experience at that point. The implementation of that plan, which is what a lot of the robotic arm was doing, things like that, probably it's been shown to really help a low volume surgeon. I don't find as much value to that in my practice. However, I do think they're combining these technologies, and that's going to keep improving with time. And I really think 10 years from now, every surgeon in every field is going to have some sort of augmented reality device to help him be more precise in their surgeries. So that is called ARIS, augmented reality. That's an exciting implementation in my surgeries. A lot of you heard of the Jiffy Knee approach. I was the 14th or 15th Jiffy Knee surgery in the United States. I think there's 90 to 100 of us now. So what that's about is trying to find a better approach to get into the knee joint. Traditional knee replacement has a midline incision. A lot of times we split the quad, and obviously there's some disadvantages that people know about. I've done a lot of these quad sparing approaches this year. That's not anything new. But what I found with the Jiffy, number one, is it incorporates a lot of the knowledge we know from trauma surgeons. If you can get direct access into the body part you're working on without lifting the skin off from the tissues underneath, you're going to probably have less scarring and better skin healing. We know in knees, as you get closer to the inside of the knee, the blood flow is better, so the wounds typically heal faster, and probably a less chance of a wound complication, which is disastrous. If you get a staph infection after a joint replacement, it's a tough route for the patient. So I believe faster healing in the knee, getting a direct access into an interval called the subvastus interval that allows us to get into the knee joint without cutting any muscle or tendons. I do believe not having any scarring over the kneecap does enhance your ability to get your range of motion after surgery. And that is the most common dissatisfier after the surgery, is people complaining about knee stiffness or loss of motion and things like that. Not uncommon with knee replacement. And even with a jiffy knee, it's not always easy, but it's just one more thing to make it easier for patients. So the thing about the jiffy knee that's really embraced my interest in it is I don't have any lack of visualization of what I need to see when I get into surgery. A lot of the quad sparing approaches I used over the years, a lot of times I couldn't see everything I needed to see, and studies would show that if surgeons aren't getting exposure what they need to see, sometimes they're not putting your parts in as accurately, and that's going to be something that'll affect you the rest of your life. So I don't feel hampered by the approach, and it gets the advantage of not cutting muscles or tendons and better skin healing. So that's what the jiffy knee is about. Again, I use augmented reality in all my surgeries. I really have changed my protocols after surgery, particularly since COVID, when this became an outpatient surgery. We used to have people in the hospital for 3-4 days sometimes, and we have therapists coming to your bedside, nurses are bringing ice in you, we had the elevator all the time. But I really saw a difference as we started these early discharge. People are really struggling with issues with swelling, sometimes misdirected therapy. So I implemented something like a delayed formal physical therapy protocol several years ago after knee replacement. I took a lot of heat from that at first. I mean, it made some physical therapists kind of angry at me and disagreements and things like that. It's starting to become a little more acceptable, and it's even the Hospital of Special Surgery has implemented what they call their quiet knee protocol now. Dr. Wicklund has put out some articles about the swelling tsunami after total knee, and I'm fairly adamant that the recovery after these knee replacements needs to be done in stages. In the first stage is you need to get the inflammation down from the day of the surgery. There's no way we can do all this surgery, jiffy knee approach, putting your parts in without creating some inflammation in your knee and causing swelling. And if a patient's getting some over-aggressive physical therapy right away after surgery, it's just going to inflame it again. And if you keep inflaming it over and over and over again, some patients never get rid of the swelling ever. They get stiff knees forever from that, and they have chronic pain. So I really think you do need a quiet down period after therapy. I do think starting some fairly immediate range of motion is important, but it can't be aggressive at first. We need the swelling to rebound. So my patients are typically at home the first 2 weeks. We send a therapy machine that goes into your bed that keeps your leg elevated, called a CPM machine, to start working on range of motion, but the focus is really getting the inflammation and swellings out. Now, the problem with patients is we're all so different. And I tell patients, if we have mosquitoes lying around the room and we're getting bit by mosquitoes, you look around and some people have red dots where the mosquito bit them, and some people have giant belts on their skin. We all swell so differently from an exciting event, and you just don't know after a knee replacement. So I treat everyone like they're going to swell a lot after surgery. I require you to elevate your leg a lot, use lots of ice, and not do a lot of walking after surgery until we get that first rebound of the swelling. After that occurs, some people need lots of therapy. Some people need more aggressive therapy. Some people can just continue on a slow, gentle pace. So we aren't going to inflict any additional pain unless it's necessary. But sometimes it is. Everyone heals so differently, and the best approach to this is treat everyone uniquely, because everyone does so differently. It's so easy for us to treat everyone the same, but that's probably not the best way to do this. We need to roll at the punches, and that's how our post-op protocols works, and I found that it keeps some people out of trouble. The quiet knee approach is, and I truly believe, is going to be uniform in the next 5 to 10 years. That being said, a lot of these things that I'm doing are unique, sometimes in the forefront, and adopted later by surgeons, but I do think we still have some room for improvement. You will see videos of some people doing great at 2 weeks after surgery. That was never seen 5 years ago even. I mean, a lot of these things, like the jiffy knee approach, I think is making that attainable, but it's not predictable. It's still at heart surgery. The knee is anatomically compromised to some degree compared to a hip joint. There's no meter on it. There's no room for swelling to be contained like into the muscles around the hip joint. And it requires to get a lot of range of motion back to not feel stiff. So it still can be a challenging surgery for patients, but we made it easier for you. One additional thing that we've started is a lot of people get something called an adductor block and sometimes an IPAC block. So these are blocks that block a couple of the nerves running into the knee joint to help those first couple of days that traditionally have been fairly painful for people. In addition to those blocks, we're doing an ultrasound guided block with some long-acting anesthetic after your sleep for 6 additional nerves. And this isn't uniforming it because everyone's different, but we are attaining a point where a lot of people those first 2 days aren't so bad anymore. The pain isn't that severe anymore. That's really made it a lot easier. We've started using a medication called Dornavax, which is a non-narcotic pain medicine, and it's really reduced the need for opiates after the surgery. And I could tell you, the sooner you can get off opiates after the surgery, the better you're going to feel like you're recovering. Generally, people have a lot less side effects. And a lot of these things we are doing, the quiet knee approach, not using tourniquets, better approach into the knee, better blocks to control pain right after surgery, has really reduced a lot of the need for medication after this surgery from the opiate class. As we know, that's a problem in our country. And so the sooner we can get you off that, the better. So I'm so grateful you chose to see us to consider knee replacement surgery. We'll discuss this more at your appointments and discuss more things such as our rules of threes for our quiet knee protocol after surgery if you choose to go forward with things. So generally when you get to the point of having end-stage arthritis in your knee, bone on bone, or you've got a significant deformity in your knee from the arthritis, probably your biggest risk is to not do anything. Because what we know from the studies that if you try to live life with that, call it a bad wheel, and you're not going out and walking and staying healthy, it's going to propagate heart disease, and it's probably going to take a few years off your life. So your biggest risk when you get to that point is probably doing nothing. Now, obviously there's some risk to have surgery. Some of the things we worry about are getting a staph infection. I think we've gotten better at that. Rates in that when I started doing this 25 years ago is probably 4 to 5%. National averages are now in the 1 to 2% category recorded for staph infection. Now we're doing some unique things like using something from the Rothman Clinic called intraosseous vancomycin injections during surgery. I can tell you, knock on wood, we're running at about a 0.1% risk for staph infection, so we're doing something right with that quite well. It's not a great complication that requires more surgery, so we do everything we can to prevent that. I'm using a local company from Neenah, Wisconsin called Match Great to use positioners for knee replacements. And I'd love to have you go to the website matchgrademed.com and see what that's all about. Believe it or not, some of the instrumentations used during the surgeries don't get fully clean between surgeries, and it has some videos to watch to explain that a little better. So I really focused on that. I have some patents with that company on some of the devices we're using to provide safer surgeries for patients. One of the other complications you're up for knee replacement is like cuts. We're doing a fairly large procedure on your knee joint. It's going to cause some swelling regardless. The swelling does block some blood flow in there. So we're going to give you some really good tips on preventing blood clots. Your biggest benefit is to get rid of the swelling after the knee surgery. So the quiet knee protocol that we talked about is probably your best way to prevent a blood clot. We're using something called TXA during surgery to prevent blood loss. At the time of the surgery, we just don't see transfusions and things like that like we used to years ago. Using augmented reality to do the knee replacements, I don't have to drill holes in the bone to get alignment guides in there. We know we probably lose about a gram less of blood during surgery by doing that. So there's an advantage of using technology to get the parts where you need them to be rather than using old jigs and alignment guides. Believe it or not, most knee replacements in the world are still used by metal annie rods down your ankle and in your hip joint to try to guess where you are. And very inaccurately tries to get a standard alignment for everyone. 5 degrees is usually or 6 degrees. So using computers, navigation, augmented reality, we can fine-tune your alignment to match your anatomy and avoid a complication such as malaligned parts. I can tell you since I've adopted Harvest augmented reality, I have a lot more uniformity between patients. So I'm more precise on placement in these and accurate on getting my gauges where I want them. And I found that to be a benefit in the long run for patients and for this surgery. A part failure obviously can occur. Certainly things like your weight have a factor on that. When we step on our knee, it's about 3 times our body weight of force ends up through the knee joint on the step. So if you're 200 pounds to 600 pounds of force in your knee joint, it's a lot of force. And so heavier you are, the more likely you could have a part failure. And it also can occur more if you have osteoporosis or osteopenia. So we're a little more attuned to that than the old days. Help your risk of not having a part failure. It can occur. I can tell you I have one patient a year that might have some settling in that bottom part, particularly postmenopausal females that bone gets soft. It's a risk of the surgery, but it's unusual, and that the glueless parts that I've adopted probably have a little more tolerance to having a little movement to get themselves stable in the bones and not fail. And we're finding that heavier people have a lower rate of early failures, which we thought would be opposite. We thought if we cemented it and heavier people would have less likely of failure. We're kind of seeing the opposite with that. The biggest complication that I've had to return to the operating room with is since COVID is people going home and falling. And I've had 2 or 3 people that had some really bad falls after surgery. Some of this is we're doing better at pain management, so people just aren't having the pain they used to. So they're trying to move a little more, doing things they shouldn't be doing. So I gotta caution you, your balance is not great for the first 6 weeks or so after surgery. And we delay the strengthening and walking and things like that so you can get your swelling and range of motion back after surgery. And so we got to be careful during those periods. You oftentimes should be using a walker at first and probably a cane until your balance is back. The other rarer complications would be injuries to arteries and nerves and things like that. Those are rare things. I don't worry about those too much because they're unusual to see. Anesthesia risk, if you had them before, that's an important information for us to know. We certainly don't see those like we used to because we work people up so much better prior to surgery to make sure it's safe for you to go through with this. So that's a diminishing complication that we see. Even the perfect knee replacement, and some people can't be perfect. Most people have numbness even with the Jiffy knee incision, which is the technical term is the medial oblique subvastus approach. End up with a numb spot on the outside. That shrinks over a year, but it bugs some people. Hearing clicks in your knee, that's pretty common after a knee replacement. With a lot of these things we're doing, I tell you about more than half our patients are doing well enough at 6 weeks that we don't see them again, but there are still people that are 2-3 months in and still working through the stiffness, still having some discomfort with some of the tendons around the knee joint. Still not really unusual, and I just want to set your expectations because usually what you see on Facebook and things like that are the best of the best. Not everyone's healed in 2 weeks. It can take some time still in some patients, so you have to be prepared. You might have to have some patience with this. Your knee may not respond like other people after the surgery. So that in entirety, we're talking small percentiles of a major complication. Again, your biggest risk is probably to do nothing and just live with pain and not be active. I think that your decision on whether it's time to surgery really should be pain related. That's been beat into us in training and things like that. This is a surgery for pain relief. And that should be your main determination on proceeding with this. Some people have drastic deformities or knee and moderate pain, but when I'm talking about pain is I have patients who will come in and say, boy, it just bugs me when I'm going up my steps or down my steps, but the rest of the day it's fine. You probably shouldn't be having a knee replacement if that's all it affects you. You can live around a problem like that. It's affecting a small portion of your life. But if you're having problems going for longer walks on a regular basis or you have soreness throughout the day, particularly if you have night pain, time to think about the surgery. And we'll talk more about that at your appointment. One of the cool things we implemented as part of our post-op quiet knee protocol is a remote monitoring program called Inkwell. So our patients get a temporary tattoo placed on the inside of their knee. You're doing daily photographs with your iPhone and your range of motion. I bet you are swelling. It was some degree of anxiety for patients to go home right away after surgery, same day surgery, and potentially not see a physical therapist formally for the first 2 weeks while they're working on rest, ice elevating, and getting rid of their swelling and not walking a lot, not getting in your car and driving places. So AQL has been a great thing for us. We do it with a physical therapist following you on a regular basis remotely. So we know exactly if you're getting into trouble with anything. We get alerts on our computers that you're struggling with something with your range of motion and swelling that we need to intervene. So we have our eyes on you all the time after surgery, and our patients have to give us a positive feedback on what that can use for your comfort level being at home in the first 2 weeks. Appreciate your time, and we'll see you soon.